So where diabetes type 1, we talked about how it's has a lot to do with the inflammatory system kind of turning on itself, and in that way it's an autoimmune, or it becomes an autoimmune problem. There are some studies that are coming out now that are showing there's some autoimmune component to diabetes type 2. But when I was in school, which is not that long ago, it was made very clear to us that type 2 is not autoimmune. So I don't think it's a very well-defined thing at this point. The big differences here is, yes, they're both genetic. One may or may not be autoimmune. The other certainly is. Is the difference in the amount of insulin and how the insulin is used. With type 1, often they have very, very little insulin that's being produced, maybe none at all. Certainly they get to a point where all of the little bit of insulin they have used is taken up, and that's when they end up in diabetic ketoacidosis. But with type 2, it has to do with those insulin like desensitivity and the insulin receptors, and all of that happens, mostly because of problems with obesity. Obesity plays a huge role in diabetes. About 80% of clients with type 2 diabetes are obese. Remember, we talked about all those adipokines that are released from the fatty tissue, adiponectin and leptin and all of that. We talked about a little bit how those are play. But one of the things that those adipokines do is they change the efficacy of the receptor sites on those the cells. So exactly what we're talking about here, this change in the way those receptors are used or can be used. A lot of that comes from metabolic syndrome and the way obesity can affect metabolism in your body. So weight reduction is actually associated with an improved insulin sensitivity and can actually change your glucose tolerance level and make it so that you are able to use up that insulin that glucose that is in your blood. Being able to control your weight and diet and exercise and all of that, especially if you're in like a pre-diabetic or pre-glycemic state, hyperglycemic state, those things are actually really effective. And that's usually the first line doctors will use rather than putting someone on medication. Although we will talk about some of the medications later. Just in case you missed the last video on metabolic syndrome. Metabolic syndrome is that group or a constellation of abnormalities in the body. There's 5 things I believe that make up that qualify for you metabolic syndrome, and I think you have to have 3 of them. It's definitely something you should know for NCLEX. It would be like abdominal obesity, so like visceral obesity, high triglycerides, low HDL, hypertension, and then hyperglycemia. When you put all of those things together, you're at an extremely high risk for becoming diabetic. So if you look here at this is from our other video, but you can see these kind of adipokines that are being released. You got your resistin, adiponectin, leptin, visfat. Really what's kind of frustrating, I guess, is that we've got this adiponectin, which is actually doing some pretty great things. It's decreasing atherogenesis, so the beginning of atherosclerosis. It's decreasing insulin resistance, decreasing gluconeogenesis and glucoproduction in the liver. So it should decrease our blood glucose. Unfortunately, it's not like the more fat cells you have, the more of this stuff is released. What happens is you don't have more fat cells. As the fat inside of this, like the fat center of your adipocyte begins to collect more and more, this part here grows, and it actually causes the cell to become like misshapen. And instead of just releasing more of the good stuff and more of the bad stuff, it just goes all haywire. And usually what ends up happening is we actually get a lot less of this adiponectin, which is kind of the good stuff that we need, and end up with higher levels of some of the others that are causing inflammation and causing insulin desensitivity. So if you look here, it just talks about, you know, the more higher you have, like the more visceral obesity you have, it's basically going to increase your fatty acids, and then it's gonna end up with beta cell dysfunction. If you see the word lipotoxicity on a test, that's all they're talking about, is that the way that all of those adipokines that are going crazy that we just talked about over here, the way those are like affecting the beta cell and causing them to not work properly can be termed as lipotoxicity, right? And then, yeah, it's going to, of course, it's going to inhibit the glucose uptake in the peripheral, kind of mostly skeletal muscles. And you remember that those GLUT4 receptors are the only ones that need insulin, that need insulin to get glucose into the cell, and that those GLUT4 receptors are located on fat cells and on muscle cells. So that's why we talk a lot about skeletal muscle in this unit. And then one of the other things that ends up with when you have you know, kind of wonky adiponectin and leptin and so on, is you end up with a decrease in insulin sensitivity, or hepatic insulin sensitivity, meaning normally insulin will trigger the liver to store glucose as glycogen, right? So if you have decreased insulin sensitivity, you're going to end up with decreased storage, meaning instead of taking that glucose out of the blood, remember we kind of drew it like this before, we're taking that you know, these lone kind of glucose molecules out of the blood and stringing them together in a nice little glycogen chain, and then, you know, putting them into the liver for storage. Obesity and metabolic syndrome actually kind of inhibits that whole kind of communication system, and so that's not happening, and all of these glucose cells are actually remaining in the blood, or protein, whatever, they're remaining in the blood. So that's a real problem. And then one of the other things it's good to know for a test is that these adipocytes, again, the bigger the adipocyte is, the more wonky it is at releasing whatever it normally releases. And one of the problems is that it can start to release or trigger more of the renin, angiotensin, aldosterone kind of components. And remember, when you go all the way down to the end of the RAAS, which you can check out in the video I did on hypertension, once you get all the way down the RAAS, what the real problem is, well, in terms of fat accumulation, is this angiotensin 2. We know angiotensin 2 does vasoconstriction, and then it's going to trigger that aldosterone and antidiuretic hormone and all of that. But for what we're talking about right now, it's this angiotensin 2, because angiotensin 2, not only does it do all those crappy things we talked about, it's also going to increase your body fat accumulation, meaning it's going to pour more and more and more fat into those adipocytes, but it's also going to increase insulin resistance. So it's going to make those cells even less likely to be able to use the glucose. And so this would be a good test question, because if you think about, because all of these things are so comorbid, you've got symptoms like hypertension, high triglycerides, all of the stuff that contributes to coronary artery disease and then acute coronary syndrome are very, very similar to the things that are contributing to diabetes type 2. And very, very often they are comorbid. And so when we want to put somebody on medication for, let's say, high blood pressure, one of the things that we can put them on is an ACE inhibitor. And when you look at that, that's a great first-line treatment for somebody who is suffering with comorbid, you know, or at high risk for coronary artery disease, and also is pre-diabetic or diabetic, because it's kind of getting in the way of this angiotensin being made. And so it's actually going to inhibit some of what the body is doing in terms of increasing the body fat and decreasing insulin sensitivity. So it's like one medication that can kind of do two things. It's a really good thing to remember. Might show up on a test. Okay, so Free fatty acids, I mean, it just kind of makes sense. We talked earlier about how an increase in free fatty acids basically ends up meaning a beta cell dysfunction, right? So it also, free fatty acids reduces that hepatic insulin sensitivity that we just talked about. And ultimately, that increase in these free fatty acids kind of floating around is going to increase the amount of glucose in your blood. It does it a few different ways. They're all listed here, but I think we've pretty much gone through them, so I don't think we need to go too bonkers into that. So free fatty acids are normally diverted to the liver, skeletal muscle, heart, and pancreas, I believe. And so not only do you end up with this increase, cholesterol, you can end up with things like non-alcoholic fatty liver disease, or alterations in the release of those adipokines.